Me here is Dr. Abibat. Dr. Suberu, okay. I used to call her Dr. Abibat. Okay, so the topic is actually, what we're focusing on this actually is actually how to be able to recognize congenital heart disease. A lot of the time, the truth is that we miss them in general practice. We miss children with congenital heart disease, and sometimes we get to a certain age when some things are too late or perhaps irreversible before this kind of people are identified. So I think this discussion is actually targeted towards stimulating people so that they're able to recognize, identify, and perhaps draw attention and start the initial management of these kind of patients yet. I've seen quite a few, even as an adult physician. I think many of the pediatric cardiology cases I've seen in the past were actually, some of them were due when I was doing my pediatric endocrinology posting, and in the Down clinic syndrome, many of them actually have a lot of syndromic cardiac issues. What kind of cardiac problems would you say are common in children, Dr. Suberu?
I think generally, ventricular septal defects is the commonest form of congenital heart disease. As a form of definition, congenital heart disease is when there's an abnormal formation of the structures of the heart and the great vessels. And then basically they are divided into two groups, the cyanotic and the acyanotic congenital heart disease.
I believe that the cyanotic congenital diseases are the worst ones.
Yes.
They are the worst ones.
They are the worst
I also will believe that they are the ones that are more easily recognizable.
Yes, because of the reduced oxygen saturation. But at times, they may not be recognized early. And we've had a child as old as 14-year-old before the child was presenting to the first time with COF. But for that child, it was just a peculiar case because she already had some other forms of collaterals that were responsible for the oxygenation. So the child didn't have reasons to present until complications started setting in.
Okay, so we're talking congenital heart diseases now. Are they rarities? Because sometimes we try not to focus on things and we think that, well, they're not common anyway. How common are congenital heart diseases, or what's the epidemiology like?
Congenital heart disease is quite common. Generally, it's about 0.5 to 0.8% of life.
That's about 5 to 8 in 1,000, right?
Yes. Oh. And this is also higher in stillborns and spontaneous abortions. Like most of the those who go through spontaneous abortions, it's actually because of congenital malformations as a major cause. And then in Africa, it's about 0.9%. Here in Nigeria, it's about 0.35%.
Okay, so would you say that in Africa, congenital diseases are as common or more common than in the Western world?
It's more common.
It's more common.
But we have a varying epidemiology depending on the location. But
Absolutely.
when you look at it generally, it's more common.
Okay, that's interesting. That's interesting. Any racial differences, blacks, whites, and things like that?
Generally, no.
Okay.
But for specific congenital heart disease, like in tetralogy of Fallot, it's been shown to be commoner in Caucasian infants.
Okay, what of sexual predilection? Males are usually more, I don't know.
Well, generally, no sex predilection, but for some specific heart disease, like in VSD, it's commoner in females, while in left-sided obstructive lesions, it's commoner in males.
So VSD is commoner in females, but
VSD.
Generally overall,
No sex.
it's not more likely for one gender than the other.
Yeah.
Okay, so that's quite interesting. I'm not sure I was aware of that before. So how does congenital disease happen? Many people want to have a baby in Nigeria. Nobody wants to have a baby with congenital heart disease. So how does the product of conception end up developing into an embryo that has a congenital heart disease?
Okay, generally, there's no identifiable cause to say this is the main cause of congenital heart disease. Several factors have been looked into, and one of these is genetic predisposition, in the sense that once a parent has a child with congenital heart disease, there's an increased chance of giving birth to a child with congenital heart disease. And once a parent has a child with congenital heart disease, there's also increased chance of giving birth to another child with congenital heart disease. So this has strengthened the genetic factor.
So that would almost suggest that if a family has a child with a congenital disease, they probably should consider perhaps some genetic screening, or to do all these so-called anomaly scans for subsequent pregnancy.
Yes. Currently, anomaly scan is advocated for all pregnancies.
Wow. What proportion of congenital disease would you say are associated with other syndrome related things?
Well, syndromes like trisomy 21, 13, 18 have been associated with specific some congenital heart disease, like trisomy 21, which is commonly known as Down syndrome.
Okay.
It's been associated to have atrioventricular septal disease. They could have other forms of congenital heart disease, but this is the commonest form of congenital heart disease
that they have
in them. Yeah.
Interesting.
And then there are also other things that are likened to risk factors in addition to the genetic predisposition and the chromosomal abnormalities. And that's medical conditions in the mother of the child, like diabetes, because of the hyperglycemia, which could have teratogenic effects on the fetus, exposure of the mother to radiations, and then other medical conditions in the mother.
Okay, so radiations, typically things like X-ray, if wrongly done right.
Yes, so there has to be an absolute indication for that in the first trimester.
And diabetes is actually quite very common. So and its prevalence is increasing. So I won't be surprised if we're having more and more of these problems. Hopefully not, but it won't be surprising. Also, lupus is common as well. We have quite a few patients with that. What of the medications? That part will interest me.
Yes, some medications have also been identified to be responsible for congenital heart disease, and things like anticonvulsants, even vitamin A derivatives, and warfarin for some of these mothers who have.
I know that it's contraindicated in the second trimester. What trimester is the most? We don't use it throughout pregnancy here anyway, but I know that it's worse in some trimesters than the other.
Yeah.
And I know that for the anticonvulsants, sodium valproate is perhaps the worst in terms of the. Okay, so I think it's important to recognize these risk factors. And if I was to be clacking a mother whose child has some things, it's making me think of congenital disease. This perhaps are some of the things that should be running through. So how do we classify congenital heart disease?
Okay, basically they're classified into two groups, the
okay.
cyanotic congenital heart disease and the acyanotic congenital heart disease. And the basis for classification basically is the presence of cyanosis. So if there's cyanosis, you say it's cyanotic congenital heart disease. And if there's no cyanosis, you say there's acyanotic congenital heart disease. And then this could also be sub-classified based on the pulmonary blood flow.
Okay.
If there's increased pulmonary blood flow, or if there's reduced pulmonary blood flow, or obstructive lesions. And so let's take, for example, the acyanotic congenital heart disease.
Yes.
I said it could be classified, sub-classified if there is increased pulmonary blood flow. This can also be further sub-classified into pre-tricuspid and post-tricuspid, just like the name implies. Pre-tricuspid is that the lesion or the shunt is occurring before the tricuspid.
The shunt.
Yes.
Okay.
And then the post-tricuspid is happening after the tricuspid valve. The main reason or the import of this classification is the fact that the pre-tricuspid classifications, the pre-tricuspid lesions are likely to give you right atrial and right ventricular hypertrophy as compared to the post-tricuspid lesions that are likely to give you left atrial and left ventricular hypertrophy.
Okay. So are there ways to clinically distinguish between these subtypes?
Clinically, they are all acyanotic congenital heart disease. In spite of this classification, the pathophysiology is similar because ultimately there's increased blood flow to the lungs, which is what triggers the other features that the patient will present with. So it's for treatment that you would need this subspecific, but clinically they are likely to present the same way, and then the location of the murmur is another thing that can give it away that, okay, this is what I'm likely to do.
Okay, now you said that the pulmonary in acyanotic type, the pulmonary blood flow can be increased.
Yeah.
That means it can also be decreased.
It can also be
Does one
decreased.
have a better prognosis compared to the other?
Yes, the obstructive lesions has a better prognosis, but it also depends on the degree of obstruction. If it's a mild obstruction, they could go on for several years before ultimately having coming down with features and complications. complication.
Okay.
But for the severe obstruction, they can even present more earlier than this. And
so what are the examples of the ones that are associated with decreased pulmonary blood flow?
Things like pulmonary obstruction, pulmonary stenosis.
Okay.
Yes, that's one of the other obstructive. Pulmonary stenosis, that's the main thing. Then other obstructive lesions are aortic stenosis, completion
of the aorta. Okay,
yeah.
okay. So that's for the acyanotic. Now, the clinical presentation of the two, I've asked you if they present differently, but of course, from the name, we know that one presents with cyanosis and the one does not present with cyanosis. Before we go into that, what's the pathophysiology? What are the pathophysiological changes that happen in these acyanotic lesions?
Okay, like I mentioned earlier, the shunt lesions, pathophysiology is similar. So we'll take, for instance, VSD, because that's the commonest we have. And then it can occur in isolation, just an isolated VSD, or as a component of a complex congenital heart disease. And the hemodynamics varies, depends on the size of the defect. Because if you have a smaller size, the degree of shunt will be smaller, and then the child is not likely to present as early as someone who has larger size VSD. But in addition to the size, the balance of the pressures, the pulmonary vascular resistance and the systemic vascular resistance is another thing that would determine when this child would present, when this child would begin to have symptoms. Typically, VSDs would not present in the few weeks of life, the first 6 weeks of life, and that's because the pulmonary pressures are still high, and so the pulmonary resistance is high. So the degree of shunt is minimal. There's no or minimal degree of shunt. But after 6 weeks, when the pressures are basically low, you now have more of the systemic pressures are now much more than the pulmonary pressures. There's now a significant shunt across those defects, and then the child becomes symptomatic.
And so, what are the consequences of the increase in pulmonary blood flow in this kind of shunts?
Yes, once there's increased pulmonary blood flow, like from the image, there you can see there is a shunt from the left ventricle to the right ventricle, and this is going into the pulmonary circulation. In addition to whatever was originally coming to the right, there's also some volume from the left ventricle, all going to the pulmonary circulation. So the pulmonary bed is flooded. There is pulmonary edema. Because of this congestion, there is compromise of the lung compliance, and as such, there's some degree of the oxygenation capacity of the lungs is reduced, and then this would cause increased work of breathing in the child, which we could see as some form of respiratory distress in the child. Then, because of the shunt that has part of the systemic circulation has shunted to the pulmonary circulation, there is reduced systemic. Yes, there's reduced systemic circulation, and this would also worsen the tissue hypoxia that this child would have. And as such, as a response, there's increased release of catecholamines.
So, what's this so-called Eisenmenger phenomenon?
Yes, Eisenmenger phenomenon occurs, is a form of chronic complication that occurs over time because of this exposure of the pulmonary vasculature, the pulmonary bed to increased pressures. There's some irreversible changes that occur along the pulmonary vasculature. So as a result, this causes further increase in the pulmonary pressures, and it gets to a point where the pulmonary pressures equates the systemic pressures and even overcomes it, and then you now have a reversal of shunt. It now becomes a right to left shunt. And this is not the point we want our patients to get to.
So when that Eisenmenger event or phenomenon occurs, does the patient usually get better or gets worse? I mean, the shunt that
initially it appears like the child is better, like at the point where the pressures are equating, there's no significant shunt across the defect. So it appears like the child is better, and you see some parents might be very happy. They think, oh, this child is doing well. They begin to default from clinic. They stop taking medications, and these things still keep going, and gets to the point where there is now reversal. That is the point where there's now pulmonary hypertension, the child becomes cyanosis, there's now cyanosis, and then with the other things that comes with that, there's tissue hypoxia, there's deteriorating clinical states.
And that state, many of those conditions, are they still surgically reversible?
No, although you still need, if it's the early stage, you still need to do the reversibility testing to know if it's something that would be amenable to surgery. But once pulmonary hypertension has set in, the prognosis is very, very poor, and it's not likely the child would do well with correction.
Okay, having talked about that, how about the cyanotic conditions? In what way are they different from this?
Okay, in cyanotic conditions, basically what happens is there's a point where there's a mixture between the deoxygenated blood and the oxygenated blood. And then normally the right-sided carries the deoxygenated blood and the left-sided carries oxygenated blood. So, unlike in the acyanotic, there's a defect, but the defect is moving
from left to right.
But mostly in cyanotic, there's either a right to left or there's a common path where this
blood is mixing up.
Yeah, so as a result, it decreases the oxygen level in the blood. And
that's in the blood that goes to the systemic circulation.
That goes to the systemic circulation. And then, okay, there's an example here. That is the tricuspid transposition of the great arteries, which is one of the
cyanotic
congenital heart lesions. In this case, there's no defect, so to say. There can be defects, but at times you could have CGA with intact septum. We call it CGA with intact septum, where there's no defect, and yet the child is cyanosed. And what really happens here is that the aorta takes off from the right ventricle.
Okay, instead of taking off from the left
ventricle. And why the pulmonary artery takes off from the left ventricle instead of taking off from the right ventricle. So because of this, there is the circulation. Normally it goes in series, from the pulmonary to the lungs oxygenation, and then it comes back to the heart,
then to the systemic circulation.
But once you have a TGA with intact septum, what happens is there's a parallel circulation. The pulmonary is on its own, the systemic is on its own. And so the deoxygenated blood keeps going from the systemic circulation back to the right side of the heart, goes back to systemic circulation. And then the oxygenated blood still goes from the left side of the heart back to the lungs and that. And this lesion is one of the examples of the doctor-dependent lesion. In the sense that a child that is born with this would need the ducts to survive in that first few.
That's the only thing that can cause
some of the blood from the pulmonary circulation to pass through to the aorta.
That's quite interesting for me. Which other notable cyanotic congenital heart disease would you want to mention about?
Okay, there's truncus arteriosus. Truncus arteriosus basically there's a common trunk. As part of the embryology, there's the truncus itself, which is in the course of the development, there's a septum, the conotrochal septum, that separates the aorta from the pulmonary. So when this septum fails to occur, or there's some issues with that septum occurring, completely separating the aorta from the pulmonary, there's this common path between the aorta and the pulmonary. So we call it a persistent truncus. And this is also one of the examples of this.
So and that needs to mix up of blood as well. Okay, so what are the clinical features of this cyanotic congenital heart disease?
Well, primarily it's cyanosis. Then there's something I need to mention, tetralogy of Fallot, which is actually the commonest cause of cyanotic congenital heart disease, especially in our environment. And typically they have 4 anatomical components in TOF, which is there's an infundibular stenosis. It's a pulmonary stenosis, but it's infundibular, the part of the pulmonary that is stenosed. And then there's an overriding aorta and large unrestricted veins. When we say unrestricted, it means it's large, so they're just free flow. Yes. And then there's, because of the pulmonary stenosis, there's right ventricular wall hypertrophy. But it tries to overcome that resistance. And this is slightly more common in males than in females. And the degree of obstruction correlates with the degree of cyanosis and timing of presentation. If this obstruction is severe, the child is likely to present early because it will be obvious to the mother that this child is blue, and with fatigue and other symptoms coming. But if obstruction is not severe, it will take a while. They will just notice that this child gets tired easily, squats, and the parents could mistake it for being lazy, not knowing that this child actually has some form of congenital heart disease.
So now the clinical features of the cyanosis, what are the things we'll see in these children that will know that something is going on here? You've mentioned the cyanosis.
Yes, cyanosis, and then
how easy is it to see this kind of cyanosis in us Black African people?
Well, it's easy. You look at the lips, the tongue.
Okay, so even for laymen, of course, I'm a doctor, I can recognize cyanosis. So even so through the lips, so you can see that this person has typically dark lips.
Dark lips. And not just the outward lips. You could see some people with dark outward lips. By the time you flip, you will appreciate that inside is pink. So it's not just the outward, but looking inside. You see
so the mothers often
like
notice
dusky, dusky discoloration, and even the tongue. And this don't seem to worsen when the child has cried or any form of
stress.
Any form of stress.
Where else do laymen often notice the cyanosis? Any other part?
The nail bed.
The nail bed.
The nail bed. You could see that it appears blue or dusky. Yeah.
So apart from the cyanosis, what other major thing can we look out for that will highlight us that something is going on here?
Yes, dyspnea on exertion, or getting tired easily. In fact, a number of parents, they try with you, they will give you the description. After walking for a while, the child just squats and trying to regain some strength before continuing
the walk.
So a number of times he gives it away, and then there will also be complaint of poor growth, especially when you have older siblings. The mother could compare with the other siblings, like this child is not growing the way the older siblings should grow. And for the infants, the mothers could notice that after the child has cried, there is this increasing bluish discoloration of the lips and the nail beds whenever the child has cried, and this could heighten the suspicion of TOF in such children.
Okay. What of the less common, any less common presenting patterns or things that we can say a presentation of this kind of people?
Okay, well, because of this relative, they have this relative hypoxic state. They increase this seem to stimulate the bone marrow for production.
So they have that polycythemia. Yes. What's the kind of highest PCV you see for this kind of people? Does it get up to 60%?
Obviously, yes. Yeah, they have a very stable high PCV. However, the definition for polycythemia appears still used for them. Once it's more than 64%, or once it's more than 70%, or between 64 and 69%, and the child is symptomatic, you need to treat the polycythemia. Okay,
so what are the doctor-dependent lesions now, and how do they present differently from this?
Doctor-dependent lesions, like I mentioned earlier, TGA is one of them. There are other examples of doctor-dependent lesions, and just like the name implies, they depend on the duct.
On the ductus arteriosus being patent.
Yes, being patent to survive. And what really happens here is there is we could talk about, for example, when we have TGA, we said there's parallel circulation. So that duct serves as a pathway for systemic and the pulmonary circulation to mix
together,
to provide oxygen into the tissues. In addition, we could have something like the hypoplastic left heart lesions. What really happens is there's the left-sided is hypoplastic. Depending on the degree, it might just be the aorta, or including the left ventricle, and even as far as the mitral valve. So as a result, most of the blood is in the pulmonary circulation. It goes from the right atrium to the right ventricle, and then because of the comes back to the left atrium. But because the left ventricle is hypoplastic, most of this blood goes back to the right atrium. So it just keeps circulating, and you have little or no blood getting via the left ventricle to the systemic circulation. So you need a duct so that they are pushed from the pulmonary artery into the aorta to supply the systemic circulation. So patients with these, in addition to the cyanosis, they are also likely to come down with features of reduced cardiac output.
Okay, I want them to hear you very well. Put this on your side so they can hear me too. Yeah, that's fine. So now you mentioned some of the clinical features of cyanotic congenital heart disease. You mentioned respiratory distress, getting tired very easily, failure to thrive, not growing very well. I can also see on the slide syncope. You mentioned earlier there could be a positive family history. because congenital disease tend to probably run a bit in families. But when we see these patients in clinic as a GP working in one district hospital, what are the things that you look out for when I'm examining a child like this?
Okay. For a child who has complaints and comes to you,
okay,
like I said, the commonest in our environment is VSD.
Okay.
So they are likely to come with complaints suggestive of heart failure in the child. The child they notice the breathing is very fast,
Okay.
or the child there is this pausing. The child is not able to sustain sucking for a long time. Pauses in between feeds.
To rest and catch
Yes,
his breath,
to rest and catch his breath, and the child is not growing properly. So these are the typical complaints the mother is likely to come to you with, and then you begin to probe further. What is the age of this child? When did the mother first notice it? Has there been recurrent chest infections in the child? Has the child been to a hospital before now? Has there been any notes or any complaint of picking anything that suggests congenital heart disease? But surprisingly, some of these patients could have even just come for some other complaints entirely. And then in the course of examining, you are able to pick one or two things. So in examining this child, what strikes you? The first thing you want to do is general examination. Okay, so you want to look at the facie of the child. We mentioned some of these chromosomal abnormalities could also, to associated with congenital heart disease, something like Down syndrome. So they have a particular facie that's, once you see it, it strikes you that this child likely has a Down syndrome, and then features of respiratory distress, cyanosis, which is typically the central cyanosis, and then want to see, is this child plethoric? Want to see a child that's plethoric, it gives you an idea that you could probably be dealing with a cyanotic congenital heart.
Polycythemia.
Yes, absolutely. Polycythemia, yes. And then fetal edema, not typically seen in young infants, but when you do see it, even in older children, it's more of a right-sided heart failure, or for a child who has a biventricular failure. Yes, and then the anthropometry is very important because we said poor weight gain is one of the things these children could present with. So you need to take the anthropometry to objectively say this child is small for age. And then we said there'll be features of respiratory distress, intercostal recessions, tachypnea, and by the time you listen, you might be able to pick crepitations, rhonchi, because of the pulmonary congestion. And then the cyanosis, you do a pulse oximetry. If the pulse oximetry is normal fine, more than 95%, you know this is normal. And then in the light of this, you could possibly be dealing with a cyanotic congenital heart disease. But once it's reduced, less than that, you know you're likely dealing with cyanotic congenital heart disease. But there's a word of caution here. At times, even those with acyanotic congenital heart disease can get some form of complication, like they have a coexisting pneumonia, which would cause a desaturated state. Yes. So how do you differentiate a child with acyanotic congenital heart disease who has a reducing saturating state because of the pneumonia from a child who originally has a cyanotic congenital heart disease? So that's what we'll talk about, the hyperoxia test.
Like giving oxygen to
yes. Hyperoxia test is giving 100% oxygen. You give for 10 minutes, and you recheck the pulse oximetry. For those with pneumonia, there will be significant improvements in the pulse oximetry. Like a child is having 89%, you comment on oxygen, it could go as high as 97%. You know this is acyanotic with a pneumonia. But if the child is 87 with 100% oxygen, all you're getting is 89%, then that tells you this is most likely a cyanotic congenital heart disease. And then another thing you want to look out for is what we call differential cyanosis. We talk about differential cyanosis when you have there's more than 3% difference in the pulse oximetry of the right. Yes.
But pulse
of the right.
Fluctuates a bit. 96 and so on.
But at times when you get to a steady state. Yes. And so once there's a greater than 3%, consistent greater than 3% increase between the right limb, the right upper limb and the right lower limb, you begin to think, okay, appears there's a right to left shunting across the top. So you want to ask, why is this so? And then why there would be that is, if you look at this diagram there, you could see the branches of the arc of the aorta. The first branch there is the brachiocephalic artery, which further divides to the right subclavian and the right common
Carotid
carotid,
artery.
and the right subclavian is what supplies the right upper limb.
Absolutely.
And then there's the left common carotid and the left subclavian.
Subclavian.
So once there is a ductus arteriosus, it's typically opposite junction of the left subclavian or a little below the left subclavian, where the left subclavian arises from. So the right subclavian would have been given off before the shunt occurs. So the right subclavian is, the right upper limb is getting, the oxygen saturation is equivalent to what has left the heart.
Okay.
Do you understand? But why on the left upper limb, whatever is getting there is after the shunt. So there is, because of the right to left shunt across that ductus, there's a reduced, yes, oxygen saturation. So once you're able to demonstrate this, you know there is a PDA with a right to left shunt. So you want to know, okay, what are the other things that would have been that you're dealing with? Are you dealing with pulmonary hypertension? Because in pulmonary hypertension, you have a right to left shunt across the PDA. Or are you dealing with a critical aortic stenosis? So these are the other things
so
you want
differential SpO2 can give some of the information that you are had to
yes.
wait until your categorization to find out.
Yes, yes.
Okay. Is there another key thing that we often find on examining this kind of patients?
Yes, blood pressure is another thing we want to look at. Upper limb hypertension. We'll still go back to our previous. Okay, the picture is even.
But I know that we don't routinely check blood pressure in children.
We don't. But it's something we should try to start doing.
Well, hypertension is not common in children, so maybe at least when people have a reason to suspect.
It's common. It's common. It's just that it's not. It's mostly secondary.
Okay.
Yeah.
Okay. So if we check the BP in this kind of children, they can have the blood pressure in the upper limb can be much higher.
Yes, like in coarctation of aorta, and coarctation of aorta will also occur after the upper limb, usually be after the branch of the left subclavian artery. So the pressure within going to the upper limb is higher than what is going to the lower limb, because what goes to the lower limb is after the coarctation, after the stenosed part. So that differential blood pressure would also suggest to you that there is some coarctation, some form of stenosis.
Okay, any other key thing that we look for when examining these children?
Yes, the precordium. We want to inspect the precordium. Is there precordial bulge? Because for some of these babies, by the time they are coming to you, they already have some form of chamber hypertrophy, which would give you the precordial bulge and then the apical impulse. And once you're able to pick this, you already have this information in your mind that there's some degree of hypertrophy here, and then you want to palpate the apex bits. Apex bit typically in children less than 5 years is at the fourth left intercostal space, mid-clavicular line, and 5 years and above is on the fifth left intercostal space, mid-clavicular line. So you want to locate the apex bit. Once the apex bit is displaced, and it begins to you begin to add your notes together to say, okay, there's a problem going on here. You want to check for parasternal or apical heave. Checking for that basically is using your palm and
just like we do in adults.
Yes,
just like we do. Pretty small.
Just like we do in adults, and you feel that movement, and it tells you, okay, there is. If it's at the parasternal area, it suggests to you that there's a right ventricular hypertrophy.
And I think these are very important because many times when we talk about congenital disease in children, people think of murmurs, and innocent murmurs are extremely common in children for one reason or the other. So I think if we take time to do this examination and we pick something off, either something that suggests that the apex is displaced or this event that you're mentioning now are found, then it puts some credence to that murmur that maybe I should get someone else to see this child I'm seeing.
Yes, murmurs, like you said, can be physiologic, but I will tell you that even the pathologic ones are more commoner than the physiologic ones.
Really?
Yes, but in the neonatal period, they can have the physiologic murmur lasting for as long as 1 month. But as a rule, it's usually good to screen any child with murmur. Please send for further screening. Don't just assume. Yeah.
I think that's a very important point because I remember maybe as a medical officer in those days, there are many murmurs that I would have just said, oh, it's a child. We get murmurs like that all the time. So I think it's a good point that even when we pick murmurs in children, we should get it checked out because
yes, especially if there's the child is not in anemic state, because anemia, some of those other things can cause cardiac murmurs.
My takeaway from this history and physical examination you mentioned now is that number one, if you see cyanosis, it's a red flag sign. We should get that evaluated straight up. That's one. And then, of course, if we get a child that is said to be getting either easily fatigued, easily tired, or sometimes short of breath, we may not get that, but easily fatigued, easily tired.
Poor weight gain.
Excessive
sweating.
Many doctors will just check the PCV and say, oh, the PCV is even almost higher. There's nothing wrong with your child. Right? Maybe the child is just lazy. No. We get the children checked out, and then so that we don't miss an important thing that could have been remedied at an earlier age, and then nothing may be able to be done about it later. Is there any criteria that is particularly useful when we are trying to make this diagnosis?
Yes, NADA's criteria is just helps the layman to be able to identify some of these things, and we have the major and the minor criteria. Yes, so the systolic murmur, grading the systolic murmur, once it's grade 3 and above, it's one of the major criteria. Yes, and then how do we grade the murmur? Grade 1 murmur, it's usually for the trained ear, so to say. It's so soft that it's hardly picked. It's just for the well-trained individuals. Grade 2 is a soft murmur, and it's usually the intensity is less than the heart sounds. So that's the way you would be able to say, okay, this is a grade 2 murmur. Grade 3 murmur is likened, the intensity is likened to that of the heart sounds. And then grade 4 murmur is when you are able to palpate a trill. Trill is a palpable murmur. You can feel that vibratory motion when you place your hands at those valvular openings. And then grade 5 is when you are able to pick the murmur with just a part of the stethoscope.
Absolutely.
Yes, on the chest wall. And grade 6 is the stethoscope is completely off the chest wall, and you are still able to pick the murmur. So once you have a murmur greater than grade 3 or more, is one of the major criteria. That's a systolic murmur. Diastolic murmur, all diastolic murmurs are pathologic. Yes, unlike systolic murmur that we said, the softer ones can be physiologic. And features of congestive heart failure, which is tachycardia, tachypnea, respiratory distress, and tender hepatomegaly. These features and cyanosis, these 4 points have been shown to the major criteria.
So any one of those 4 points?
Any one of those 4 points. That child needs a further evaluation. And for the cyanosis, you must have confirmed that this is not pulmonary. Once the child is cyanosed, you do the hypoxia test. And once there is no improvement with the hypoxia test, you have to send that child for further evaluation. And then the minor criteria is when you have a soft systolic murmur, an abnormal heart sound. You may not be able to describe what you're hearing, but you just know there's an abnormal heart sound. Yes. Okay. An abnormal chest X-ray, you are seeing the chest X-ray, you just know there's something abnormal about this chest X-ray, or any ECG abnormalities, either a left atrium enlargement, any form of ECG abnormalities, or arrhythmias, any form of ECG abnormality, or an abnormal BP for the age, usually in the higher, more than what you expect for the age and sex.
Okay, so from this last criteria now, I can figure out that even the early investigations we need to do for this patient, I can pick that we need to do a chest X-ray, that can give us some hints, we need to do an ECG for this patient, we need to check the BP. What other investigations should be done for patients who we suspect may have a congenital heart disease? Okay,
echocardiography is the gold standard.
Oh, yeah?
Yes, in detecting congenital heart disease.
That's usually specialist setting. So if I'm seeing that person in a certain hospital where we don't have a pediatric cardiologist who can do an echocardiography, at least I'll send to get an opinion and get feedback from that place. Yeah. Where then I'll be able to be certain what's going on with that patient. If it's normal, I'll be reassured, and if it's not normal, I'll know that the person needs to have some further work.
Further care, yes.
What of other imaging? Any other imaging?
Yes, in addition to echo, or there are times even with echo, you feel you still need some information. It's not answering your questions. You could do cardiac CT or MRI, but this is at the discretion of whoever is seeing the patient. So then a more invasive procedure is the cardiac catheterization.
So as simple as the chest X-ray is, and that's very widely common, I would recommend that, of course. I mean, that can be a good initial step. So what are the abnormalities that we're looking out for on the chest X-ray?
Okay, basically once you have a chest X-ray before you, the things you want to look out for is the cardiac size, the cardiac contour, the cardiac position, and are there the features of pulmonary marking, vascular marking, is it increased or reduced? These are the things that would guide the information you'll be able to make of the chest X-ray. So in evaluating the cardiac size, we usually talk about the cardiothoracic ratio. Yes, and in determining the cardiothoracic ratio, basically you would draw an imaginary line along the spine, the midline of the spine, and you look out, you get a measurement of the widest point from that imaginary line. It doesn't have to be at the same level. So on to the right and to the left, you get the widest point
like
from
A and B on
your
slide.
Yes, and then you add it, and then you divide it by the chest diameter, and whatever you get typically is about 50%, but once it's more than 50% in older children, it tells you there's cardiomegaly. But for infants or younger, once it's more than 60%, it tells you there's cardiomegaly.
And this is usually done on a PA film, right?
AP in children, young children,
okay.
young children. But in older children, you can do a PA film.
Okay, that's interesting. So at least chest X-ray starting point, and this you've told us what the way to assess and to interpret the size and how to measure the CTR or the cardiothoracic ratio. So if the heart is enlarged, a lot of things can cause it, but basically, I mean that's the starting point for further evaluation. What other things should we look out for on the chest X-ray?
The position of the heart. So at times it appears like the heart, typically the heart is more to the left. Do you understand? But when you are seeing the heart more to the right, you want to ask questions. The first thing you want to ask yourself, where is the apex pointing to? If the apex is pointing to the right, then it tells you this is a dextrocardia. But if it's pointing to the left, it's more to the right, but the apex is pointing to the left, then this is described as dextro position, and it's usually due to some other things, probably a pneumothorax on the contralateral chest that is pushing the heart this way, or a diaphragmatic hernia that is pushing the heart this way, or even on that same side, some hypoplasia of the lung. Absolutely. So because of that, the heart is pulled towards that part.
Okay, so now this major congenital heart disease that you mentioned earlier, are there particular, I remember that for TOF, we often said boot-shaped heart or something like that. So are there particular configurations we see that will remind you or will suggest to you that does it have any diagnostic value, so to say?
Basically, it's just a shape, interpreting that shape of the heart. And some conditions have been associated with some shapes, like the boots.
Like the boots?
Boot shaped for TOF and the egg on side or egg on string for TG.
There's one water bottle art, but I think that is that's adult cardiology. I think that's I can't remember. Cardiac something like that. Okay, so boot shaped art, I think I can recognize that if I saw it. And then the egg on side shape. Quite interesting stuff. So in the initial moment of seeing a child with congenital heart disease, so if I have this child now, I recognize that this child is probably cyanotic. Perhaps I went ahead to do the X-ray and I saw one of those patterns and said, what are the initial way that a child with suspected congenital disease should be managed?
Okay.
Broadly speaking.
Broadly speaking. Okay, you want to assess, is this child in heart failure? If the child is in heart failure, you need to start treating the heart failure. And basically, we give diuretics. You want to also minimize...
How do you know the child is in heart failure?
Tachycardia, tachypnea, tender hepatomegaly. For some of this child, they already have some of these symptoms, but not yet in frank failure. Do you understand? Like the difficulty with breathing, poor weight gain, and you listen, you're able to pick a murmur. This is the kind of child you want to send for an urgent echo to be sure if there is a congenital heart disease. But if you are not able to get an urgent echo and you are sure this child is in congenital heart failure, the three T's, we talk about the three T's, the tachypnea, tachycardia, and tender hepatomegaly. Then you need to start the child on diuretics. So there are times you have even done an echo, you have confirmed the child has congenital heart disease in failure, you start the diuretics and you start ACE inhibitor. These are medical treatments we do, but ultimately is to do a definitive
correction.
Correction. Yes, because we talked about some of the complications that they can have. So it's always good to, but why this medical therapy just helps you to buy time until you are able to.
So for doctor-dependent lesions, I know that there are some things that they do and they don't do to make sure that the duct is preserved for as long as possible to support the person. Can you just give us a snapshot of this?
Yes, and for any neonate who presents with symptoms of shock, as a rule, you have to rule out, think of the possibility of a ductal-dependent lesion and place that child on prostaglandin E1 infusion, and before you now do the other evaluations for the child. This helps to keep the duct patent while you further evaluate the child and plan the definitive treatment for the child, because the child cannot be on infusion, on the prostaglandin infusion for long.
Definitely.
It's just to buy time to get make your diagnosis and do the definitive procedures.
Okay, so for the I know you still have quite a number of things that you will have wanted to talk about, but we're really out of time now, and I want our audience to take some strong points on. So, which of the congenital diseases are really amenable to treatment in Nigeria? That's number one, particularly among the common ones.
The common ones, VSD,
is amenable to treatment in Nigeria.
ASD.
Okay. Is it usually open surgery or minimally invasive surgery?
Currently, it used to be open surgery, but currently we are going. Things are changing. It's now more of the transcatheter approach.
I'm aware that Cardiocare too is going to start doing their heart surgery maybe early next year.
By God's grace.
I'm sure that I suspect that both the minimally invasive and the open heart approach will be necessary. I actually do know that most places where they offer minimally invasive heart surgeries, they have to have the capacity for open heart.
Yes, they have, yes, because it can't fail. That's one of the drawbacks or one of the complications. So you have to prepare for it. And when it does fail, you just switch over to.
Actually, outside the country, I've seen many people, many adults, many people older than me that had, as a child, I had heart surgery to correct some of these kind of things. Many of them are living fine, and it often pains me when I see.
Prognosis is good if they are picked early and treatment is started early.
Okay, so I would have to hopefully some of the points we'll be able to share later on, but we have to stop here so that we can take some questions. Can we take some of the questions from the audience, please? Let's see how much. So here we have. How sensitive anomalies can in the diagnosis of congenital disease in Nigeria? Just added Nigeria there. How sensitive are anomalies scans in picking this?
Scans generally is dependent on the individual doing how skilled the individual is. But in as much as we say depending on the individual, once any anomaly has been identified, it's better that the mother is sent to a facility where a skilled person is to check and to see if there's really any congenital anomalies. But from my experience so far, at least the few ones we have suspected congenital heart disease, the child actually, by the time the child was born, the child actually had congenital heart disease.
Interesting. Here it said that in truncus arteriosus, since the oxygenated blood gets to mixed with the deoxygenated blood, does that mean the symptoms won't be so severe in truncus arteriosus because it mixes? Does that mean that the symptoms will be less severity?
Well, symptoms is depending on the type. There are different types of truncus arteriosus and the coexisting pathology. Some of them could have pulmonary stenosis, which would also help limit whatever flow is getting to the lungs. So those ones are likely to have more features of cyanosis and heart failure. While those without the constriction will have more features of heart failure and even likely to present much more earlier than the ones with obstruction.
So basically it depends on the type. And
yes.
Some associated lesions can actually can blow that.
Yeah.
Okay, what was the normal blood pressure in children? Was surprised to hear that we do BP in children, and what conditions does an increased BP signify?
Yes, we use a chart. We have a nomogram to interpret, yes,
which and is based on age,
based on the age, the sex, and the height.
And the height.
Yes. So once you check the chart, and then there's a way you interpret it. Once it's between more than the 95th percentile for that age and sex, that is hypertension. And then you now grade it based on whatever percentile you're able to.
Okay, so basically, if we are going to check blood pressure in a child, you have to have a nomogram.
You have to have a nomogram. Although we use a rough guide by the bedside, you could say 2N plus 80, which gives you an idea of the systolic. And 2/3 of that value is expected to be the diastolic.
Okay,
that's just a rough guide.
Okay, that's beautiful. That's beautiful. That's beautiful. That's beautiful. I mean, I really look forward to when the opener things will be available. Even in the cathlab that is there already, I know that some things like right heart catheterization can actually be done already, even though, of course, this takes interventional cardiologists has been doing it over and over again. So right heart catheterization to measure these pressures, to see all these pressure drops that I'm describing. Actually, that can be seen live in that kind of situation. And I'm hoping that more and more, particularly of the minimally invasive closures, will start happening in Nigeria, because the cost and the morbidity of open heart procedures in this part of the world is still fairly high, particularly for children. So for the things that can be closed device-wise and minimally invasive, to be sweet, okay? And then additionally, when the expertise and the facilities for this are more and more available, I'm hoping that more and more children will be able to survive. I have a question that we apparently missed out. Is there any foundation in Nigeria for helping the less privileged with congenital heart disease? I know 2 patients that can benefit from them. Well, I will leave you to answer specifically, but I'll talk broadly. The truth is that in Nigeria, there are many conditions that are suffering inappropriately because of our weak health sector and probably inadequate action from our government. That's the truth. So even diabetes, heart attack, people with stroke, cancers, kidney disease, chronic kidney disease. I know a lot of people that actually are struggling to pay their bills for this. So it's painful actually. It's painful actually. And particularly for renal, for kidney patients, I try to but even those foundations that were stretched, that's the truth. So, well, back specifically to the questions, do you know any foundations that help arts for children?
Well, I know some of these institutions have corporate, social corporate responsibilities. And like you mentioned, they're overwhelmed. I know there's an MTN foundation, but I don't know how effective. And I can't say there's anyone that has benefited from it. But what I know most parents do is to go all out. Exactly. To the media, to the use all things available to you, to seek for help. And before you know, someone, what?
Many times the help comes late, unfortunately. Many times.
But for some people, they might just be lucky.
I know many people that have been lucky actually are able to get their procedure.
Yes, I also know.
But I mean, the one I can mention now is I mentioned Kanu Arts Foundation. I mean, that one is popular and well known. But I'm sure they will have a waiting list that will extend up to hundreds of people.
Yeah.
Doctor, thank you very much. Our pediatric cardiologist, it's been very interesting talking to you. I know that this kind of pediatric cardiology thing is very related to neurology, and many people find it very daunting. But I think you made it fairly relatively easy. And thank you very much, everybody, for participating. This is the last day of the symposium. This symposium is coming from Cardiocare, multi-specialty hospital in Cardiocare, Abuja. And of course, we focus on cardiovascular medicine. Our practice is across the breadth of internal medicine, especially cardiovascular medicine, neurology, endocrinology, and diabetology. We also do have rheumatology and nephrology clinics that operate here. And we have a state-of-the-art ICU, 3 ventilators, and of course, our cath lab was launched this week by the Minister of Health in person. And we're hoping that as we try to reduce the morbidity and mortality of cardiovascular disease in Nigeria, that we work together. We work together because we know that we cannot just sit on an ivory tower and imagine that we're solving all the problems. No, if we work together, we build each other up, we improve your practice, like you improve our practice, and then we can actually try to dent this issue in Nigeria. Many years back, people used to say that cardiovascular disease is the problem of the rich alone. I'm sure that none of us will dare make such statements these days. From drivers to cook to bricklayers, stroke, diabetes is affecting everybody. That's the truth. And we're in Abuja here, so we have to take the bull by the horn. And I'm hoping that even with these little interactions and education, continuous medical education, together will make the difference and in improving this. We do give doctors referral feedbacks. That is, when patients are referred to us, their patients actually go back to you with a letter writing everything where we state everything we did for the patient with the investigation results, so that the patient can actually continue his care from the doctor that sent he or she here. So that's a good one that we offer. And we want to remind that even when you are not referring the patient here, with the contacts that are here, and if you are in the WhatsApp symposium WhatsApp group, you can always throw a question to ask, or even call sometimes to just discuss the patient, get our input on the patient, and we are always happy to contribute, because our own motto and our own philosophy is that there's no knowledge that you have that you didn't get from somewhere or get from someone. So we're very happy to share that, and we've realized that over the years, as we do that, we actually learn from other people too. We learn from their practice, and it has built us up as people. So thank you very much. Thank you for having us. Thank you for sharing this time with us. And hopefully we'll meet again next year. So the CMAs will come over the next few weeks.